Right now,
happened?
that's a very good point. Okay, and that's why we created the Hawaii HealthCare. We created that as a mechanism to bring these resources to us in Hawaii for loan repayment, what have you. The comment was that across the country there are resources being put into place to get more training, essentially for whether it's pharmacists, or nurses, or physicians. However, one has to remember that it takes a long time to train a provider of any sort, particularly a physician. It takes not just the 4 years of undergraduate, and it requires they be very attentive to their studies in order to get into medical school. Then 4 years of medical school and at least 3 years of residency, so it's a commitment of 10 years at least. So in order to get ahead of that wave, that tsunami, so to speak, it's going to be a big challenge. And no number of foreign medical grads is going to be a solution for us, and it's probably not the best solution anyway. I have good friends that are foreign medical grads, but that is not the solution. Right now we have 170 medical schools in the country, so even if we provide extra resources, we only have 170 medical schools, which graduate 18,000 medical students a year. I'm simplifying, but just to make that we are hundreds of thousands of healthcare providers short, and right now we only graduate 18,000 medical students a year. So in order to, I did some rough calculations, you would have to have every medical school in the country increase their medical school class by 30 right away, all of them, in order to kind of bring parity to the projections on adding all these individuals to the healthcare system. And it's just not possible. I talked to, for instance, Dr. Hedges, Jarris here, who runs our medical school, and he's working hard at different ideas, but he can only maybe do 5 or 7 more students because he just doesn't have the facilities for it. We would have to really invest, not just the grant, but we would have to have a national movement and probably a change in focus of what is going to define, this is what again worries physicians, a change in focus of what the definition of primary health care will be. Will it be care from a cohort team of nurse practitioners and physician assistants, of whom many are fantastic, or will that be the primary health care system, and the specialty system will be peopled completely by people who went through the long program of medical school and residency? Is that acceptable to America? I can tell you, when I was working in Kau at one point, I was one of the docs at the hospital in the ER, and the way we covered the ER, because we covered it 24/7, right, was we had 3 of us. I did 1 week, then the next guy did 1 week, then the next person did 1 week, and we just rotated. And when we were off of the ER, we ran the clinic, okay? Well, we went to the community, and we said, really sweet people, but a classic rural community. We said, we couldn't just have Josh and another half-time doc on call. So anything bad happens, he'll race in, or she'll race in. Heart attack, stroke, big problems, major respiratory failure. But all the other, instead of having 3 full-time physicians, let's hire 5 additional providers, nurses and nurse practitioners, to handle the clinic, to handle some of the other routine care. The community rejected that out of hand. They really wanted those 3 physicians. And it was a big public meeting, and and I would not be surprised at all if, at least in the current mindset of the country, I'm not saying good or ill, I'm saying that it would be a major transition in thinking about healthcare. So these are questions that will continue to be a problem, but I do cite that as a major wild card in the system, because if we are too aggressive at moving to smaller Medicare reimbursements, a much broader Medicaid system, a lot of physicians could leave practice, and it would be a problem. Question, or you're signifying 5? Yeah. The concern that is expressed graphically is correct, which is a lot of physicians. We have a large number of physicians, for instance, in Hawaii that are 55 years or older that have been engaged in one healthcare system, and when large change happens, sometimes it sifts out, people move on, they retire, what have you. But if it's a very troubling situation where someone had a different expectation, they might quit altogether. And if that does happen, I think you're going to see probably major revisions of Affordable Care. That's just one thought that I have. I also wanted to kind of reiterate this idea about population health and technology. It is possible, in spite of a little bit of skepticism on my part, it is possible that over the course of 5 or 10 years, 5 years ago we didn't have this, okay? An iPad that you could quickly get pretty decent, quick. I mean, I have a friend, actually probably our sponsors, wonderful gentleman, Alan Tice, right? He's an infectious disease specialist. I really love that guy. He, when I'm out in Kohala or whatever, and I see a patient that's got a bad infection, I'm sure I break a lot of rules, but take a picture of it on my iPhone or my iPad. I ask the patient, is it okay if I share your situation with a specialist? I text it to him. He sees it, or I email it to him. He sees it on the screen. He says, Josh, make sure you incise and drain that. Or, Josh, this is a X disease. You have to make sure you give these 2 antibiotics. Or, don't forget to culture that. Immediate consult occurred in real time. Didn't require a helicopter or a plane fixed-wing transport. Didn't require an admission. I saw them the next day, probably, or I kept them for observation. And that small amount of technology did create incredible savings in time and money for that individual. And so technology could provide some game-changing events. And I know that those of you guys who are young medical students or nursing students here, you will have an iPad mini, like, for sure. And you will be able to get your MRI result from a month ago on that thing instantaneously. Wi-Fi system. Whereas a lot of colleagues that are the generation ahead of me, I will not say old farts, but they are definitely not, using technology all the time. They're a little bit more reluctant to go that direction, and they have much better diagnostic skills, and they have a much better grasp of kind of that interaction between people because they spent so many years spending time clinically and doing histories and physicals. But the system has moved away from that capacity allowance in the new era of healthcare. And that is a wild card. It could mean that we provide a lot more streamlined care and maybe we'll provide better care. I don't know. It's a good question. He didn't get paid. Very good question. Let me say what was said. So that, tell me what the question is as well.
You had a consult to a very doctor for free.
Yes.
So he.
Very good, excellent point. I agree completely. So the statement was, so I took a picture on my iPhone, sent it over to a head of infectious disease at a tertiary care hospital, and he didn't get paid anything. So why didn't Alan get paid anything? Well, one, because right now the insurance system hasn't caught up with these changes. I would say that is definitely an amendment that has to go into the Affordable Care Act.
I mean, why would he do it? I come over to my house, acquire my house, and buy.
So the question is also, so the larger question is, why would an individual participate in a system that wasn't in their own direct self-interest? And Alan he drives around an old beater and he doesn't care, right? But not everyone is like that, and also not everyone can afford to lose the work that they've trained for. So I believe wholeheartedly that as the revolution occurs with electronic health technology, that you will also have to see at the same time a structure for reimbursements. And that's another part of, if it's done well, if it's done properly, for health information exchanges. One of the reasons they're starting right out of the gate with secure messaging is because it will be more trackable, therefore it should be billable, it should be accessible. HMSA tried in a small way when they did online care, which I was not a firm believer that was a good approach at first, because I still believe in exam. I'm a family practice trained person. I think you need to do it. You have to have some physical exam. But for the purposes of consultation and extra advice, to do a 5-minute visit and have some payment to that specialist on the other end of the line makes all the sense in the world. And it might be very good for the profession because in this case, some people may not want the large overhead of a practice, or they might be in the phase of their career where they prefer to do consults from home. So there is some additional potential for technology to work. But we have to, as healthcare providers, be mindful that we don't just get ripped off in the process of healthcare change. In other words, for those who have gone through heavy-duty training and have something to offer, they should have a meaningful place at the table to discuss what's appropriate for their payment and so on. And that is one of the things I don't yet see in the Affordable Care Act. Though there is the potential for that, again, through some of these other models. For instance, and I'll take the next question in a second, if I was setting up an accountable care organization today, I would rely heavily on subspecialists that wanted to only provide a smaller amount of care in their lives but still wanted to be involved in healthcare, because it's an opportunity to both include the wisdom of those who have been much more experienced and also fit their lives in a new model which will have some shared savings. And so that's the kind of thing that smart people who drive these pilot programs or whatever you call them will do. I think I got
Question?
the neighbor islands and
Okay,
Question.
can you hear me out there, our islands and the other sites? We can have your questions ready. Just let us know who you are. Is that your question?
This is Hilo. Can you hear us?
Yes, we can.
Yeah, we have several
We
questions.
can't see you, but we can hear you.
Even better. On the state level, one issue that maybe Senator could have some influence on is tort reform. We know from other states like Texas where they've had tort reform, they've been able to attract physicians. That's an ongoing problem here. Even the state-employed physicians are not indemnified by the state. There's a private malpractice company that's fairly expensive. No tail insurance is provided, so it's a disincentive. One other just brief comment about the readmissions to the hospital. I think the law of unintended consequences is that because there's a financial incentive for hospitals not to readmit patients, what I'm seeing here in Hilo is a tendency for the ER docs not to admit patients who actually do require readmission because of the problems that the hospital then faces under the ACA. Thank you. And there's a few other questions.
let me address those. Who is that over there?
Jason Morshell.
Hi. So yes, I've submitted the medical malpractice bill I think 4 times, and I'm going to be frank. I have 26 to 28 attorneys at the Capitol, and then me. So it's been a challenge. We passed it out of the Health Committee a couple times. Let me tell you one reason I think medical malpractice reform, or at least a revision, is important. One reason is that right now the current system doesn't allow for anybody with small injuries or small malpractice events to get anything. Under $250,000 of injury means that there are no attorneys that will take the case. And if I'm speaking as a left-winger socialist type, which is not totally who I am, but some days I am like that, you can't get anything for the working class. I mean, if you have, if I chop off the end of your finger, but it's not worth $250,000, no one's going to take your case, whether it was total malpractice or not. And so the system doesn't really fit the need. We have had very, very few cases that were large in our state, and those cases could be handled with a reinsurance pool, which some states have done, and we could go to probably a no-fault situation, which I still think actually would even be somewhat palatable to the attorneys in the state, because they could litigate a lot more smaller cases and it would be a little bit more fair. So I agree with you that there should be some malpractice reform. Also, I'm really concerned about the readmission bias that you mentioned, because if people end up gaming the system to just say, look, we're not going to admit you, but we'll see you again, people are going to get pretty bad care, and a lot of people are going to die because we didn't fully rule out their pulmonary embolism, or we didn't have them completely ready on their blood thinners or any number of problems that we probably could handle in a basic way. I think hospitals are going to have to evolve, and I think that that's probably what we'll see. We'll see more, like the hospitals, if they have fewer admissions, are going to have to do something with their space. And I'm already hearing a lot of discussion about other wings and other services that will provide kind of intermediate care. Will it work or not? It seems like a bad shortcut to me, but that's the kind of fight that's going to go on in the next phase of the Affordable Care Act debate.